Hello, welcome to Senior Connections. This is our monthly show brought to you by Senior Resources, your local area agency on aging. And we exist to serve especially people older 60 and older, their family and caregivers. And we're here every month to navigate what can be a confusing network of services for older adults, things like prescription benefits, Medicare, long-term care options, and many more things. And so we hope that this show gives you some information monthly on some different services available. And so as we found as we've proceeded through this pandemic, we're finding that people are challenged in taking care of the older adults in their lives. They can't see them some of the times. They may not have been able to have their regular provider visits. And so I'm excited today to be able to tell you about a new program available to Senior Resources participants. And so it is my pleasure to welcome back my coworker, Kim Vazquez, and to welcome one of our newest team members, Laura Maclam, and she is a nurse practitioner. We're going to hear a lot more about them, about the newest program at Senior Resources, Enhanced Care Services. So welcome, ladies.
Thank you.
Thanks for joining me. So Laura, you're newest. Tell us a little bit about your background and what has brought you to Senior Resources.
Excellent. I am a nurse practitioner, and I started out my life as a paramedic as a young girl. Worked for several years on the ambulance in Grand Rapids, and went further my education and got my nursing license. I worked 5 years in the emergency room as an ER nurse, and then I flew 5 years full-time on the helicopter for Aeromed as a flight nurse. Went back and joined the trauma team at the Level 1 Trauma Center as the Injury Prevention Outreach Coordinator. Finished my master's degree in nursing and my advanced education to become a nurse practitioner. My job just prior to joining Senior Resources, I worked for a private practice doing pain management. We worked with a large spectrum of patients, both managing chronic and acute pain, both with medication and interventional therapies. Prior to that, I worked as a nurse practitioner for a geriatric practice, caring for older adults both in long-term care, subacute rehab, as well as living in homes for the aged or assisted living facilities.
Wonderful. Well, it sounds like a very, and you can't be old enough to have done all of those things, so I know you started as a young girl, but we'll talk a little bit more about some of that. But Kim, tell us a little bit, remind our viewers of your background. You've been with us before under a different title.
Yeah, under a few different titles. So I am now the Medical Services Administrator. I started out with Senior Resources as an options counselor, and then developed the options counseling department. And from there, I went to oversee the Access Services Department, which is like a lot of our case management programs. And from there, now we have developed a new medical services program for Senior Resources, so going in a different route. Senior Resources has always been well known for our case management programs, really instituting home and community-based services. So this is a whole new realm for us to be providing medical services to our participants.
Right, absolutely, and it's exciting, and I'm really excited to delve into that a little bit. So let's talk about this new program, Enhanced Care Services. Kim, I know because you are really the instigator of all of this. Tell us about
how you use the word instigator.
It's in a positive way, but this was really your brainchild. So talk about how this came about. You mentioned that it's a new thing for us, but how did we get into this?
Well, there's quite a few different reasons why we went down this road, but one of the frustration points for us has been that we've seen our participants really over the years steadily decline between assessment points. So we might see someone every 90 days or 180 days, and 59% of our participants actually declined during that time. And the frustration came in because we saw a lack of intervention during that time period. And so we really wanted to be able to institute change so that we could see our participants improve, hopefully, or at least maintain their physical function. And we know in order for that to happen, we have to be able to oversee some medical services for that individual. So on top of that, we also noticed that we have quite a few of our participants that were visiting the emergency room or the hospital. And again, our entire mission is keeping people in the home as long as possible. And in order for us to keep people independent and keep them in the community, which is what most people want to do, they need to be able to remain strong and healthy. So how could we institute change for those people and get those outcomes that we would like to see for our population as well as they would like for themselves? So that's where we came upon the idea of enhanced care services.
Great. So you do need to be a participant in senior resources programs. Why is that?
Really, as I just said, we do these assessments by our nurses, social workers, and our community health workers. Go out, see the individual, they do a comprehensive assessment, both medical and social, and really are looking at those points that we want to see change. How many falls are they having? Are they moving as much as we would like to see them move so that they can maintain that physical function? So we need to be able to gain that baseline. Plus, our supports coordination programs are all designed to add support, another layer of support to that individual to help them engage in any services that might benefit them within the community. So we want to make sure that as a team, we are really wrapping that person around as many services as appropriate for that individual.
So one of the functions, or one of the enhanced part of the enhanced care services, is the nurse practitioner. This is our first time that we've, as you said, we have nurses on the team.
Right.
And we have social workers, and we have other all kinds of things. But our nurses don't do a lot of hands-on. There's like blood pressure checks and things like that mostly. But now we've got Laura, who's a nurse practitioner. So let's start by telling everybody a little bit more about the difference between a nurse practitioner and a nurse, and what you'll be able to do in this role.
That's a good question. So a registered nurse, typically follows orders that are given by a physician. And so they'll evaluate and assess a patient and then report those findings back to a physician, whether they're in the hospital or in a clinic setting or even in a community setting, and then look for direction and maybe make suggestions that are usually well-educated suggestions. As a nurse practitioner, I have the ability to diagnose as well as prescribe and order tests. And so that's the difference between a registered nurse and a nurse practitioner, is I have an advanced degree of past boards to become a nurse practitioner. I can prescribe medications, things like everyday blood pressure medications or diabetes management, once in a while medications such as a pain medication, or looking at things the way maybe somebody has an acute infection and I can prescribe an antibiotic for that patient as well. I can order tests, whether they're lab tests or x-rays or radiology exams. I can also review those results with our supervising physician or with the patient's and the participant's own primary care physician, as well as the ability to make referrals. If someone needed a referral to a cardiologist or a neurologist or a podiatrist, I'm able to make all of those referrals independently and don't need a secondary prescriber on that.
So you can do that even if the participant has another primary physician. So that's a big difference, where if one of our nurses went in, they might see something, but they would have to call the primary physician because they can't make the referral. They might call or somehow contact the office and say, I'm noticing that this is going on, but they can't do anything more than that, really, right?
Our goal is to work in partnership with the patient's primary care physician. Most often, lots of our participants and lots of our patients have a strong, lasting relationship with their primary care physician. So we're not looking to take that away or take that off the table. We're looking to add another layer of support. And so it's another avenue of communication where I have the ability to communicate with that primary care physician to report physical findings that I'm actually seeing in their own home or at the bedside, and able to maybe help coordinate care a little differently than what, as we all know, it seems like every time we go to the physician, the visit gets shorter and shorter. And a lot of our patients and participants are complex. They have 6 or 8 or 12 medical concerns, and they take 10, 12, 15, 20 pills every day. So to have an opportunity to review all of those for interactions, optimizing, reducing pill overload and burden, and de-prescribing medications, we have the ability through senior resources and the enhanced care services to spend that time with a patient.
That's wonderful. I mean, I can see the time. There's something to be said that's so important about being in their homes. You can look, and I know this is the kind of thing our sports coordinators do too. You look at the environment, you look to see if they're a fall risk, you're looking to see if they have food in their refrigerator. the basic social determinants of health thing that's so important. You know, is it a safe place? Do they have heat? Is it too hot? You know, we're in summer, all those kind of things. And I would imagine, get a very different picture of being in their home, not to mention the extra time. And that's not at all to say, I mean, I think our doctors most of our providers would love to be able to have more time. There aren't enough of them, as you've said before. And I really love the enhanced part. That's what I keep coming, enhanced care services, and it just clearly is. So who makes a good candidate for this kind of a program?
Really anyone that has one or more chronic disease conditions that needs assistance in managing those. So beyond Laura, our nurse practitioner, to go out and see that individual, the patient, and develop a care plan with them, we also do remote patient monitoring, in which we ask the patient or a caregiver or support system to be able to answer some basic questions. Each question set is about 14 questions that is really detailed to what their chronic disease condition is. And they do this on a regular basis. It might be once a week, it might be 3 times a week, depending on what Laura feels is appropriate for their condition. And that gives us a baseline trend to start looking at. If there's any changes, then we could maybe catch that symptom early on before it becomes really a much worse situation for that individual and leads them into maybe an ER visit, because ultimately that's what we're trying to avoid, is use of the ER when it doesn't necessarily need to be the ER. We could address it in the home environment. So that's what we're trying, that's what we're looking to do. We want to keep people in the home, and I liken it often to Doc Baker from Little House on the Prairie, if you remember that. Really trying to treat at home.
Right.
You know, if we can treat it at home, that's where we want to be.
And so we're perhaps communicating more frequently too, or you said sometimes it might be, before it was a 90-day or 180-day thing. Sometimes you might be, doing with the remote patient monitoring, you're able to check on them much more frequently.
Correct.
So if you knew there was an infection, you could be checking
Right.
a couple of times a week if needed.
We might catch that symptom much more early on because there's a change in their blood pressure or a change in their temperature, something that's going to indicate that there's been a change that needs to be reviewed with the nurse practitioner to see what intervention needs to happen.
So if you're doing remote patient monitoring, how does that happen?
So remote patient monitoring is a form of telehealth, and there's several ways that it can be done. They can do it through a technology basis in which an individual just needs to have a smart device. Could be a cell phone, could be a tablet connected to the internet. They just press the application will tell them that it's time to do their protocol or their questions, and they just hit on it and answer the questions, and then it automatically sends to us. So for those individuals that are able to do that, and people are getting better and better at technology all the time,
And the
it's
apps
all
are getting
around
similar,
us.
I think, too.
They are more user-friendly,
Yes.
and our platform is very user-friendly. And it also has, with every time it asks if they would like to speak with a nurse, so that at any time they would like to speak with a nurse, it will message us so we can see that right on our platform.
Wonderful.
And then as part of that platform as well, they're able to do a telehealth visit. So at any time we needed to schedule a visit in, and say Laura might be in Holland at the time, and they're in, say, Muskegon. Laura might have time, in between a visit to stop and remotely do a telehealth visit with that individual for 10 minutes or 15 minutes to resolve an issue that they might be having. Also, remote patient monitoring for those people that don't have the ability to do the smart device. We also offer a community health worker to call them, again, on a basis that's needed to gather that input. So in other words, we're asking maybe, what is your blood pressure? What is your weight today? And gathering all of that information from them on a regular basis.
So we're really able to keep much closer tabs. And just really it just is really kind of an amazing thing to see what a difference that is from what we've been able to do in the past.
Absolutely.
It's exciting.
Again, it really just keys in on the smallest symptom change.
So you're going to be tracking all these outcomes,
Yes.
and you're going to have some wonderful reporting, I would imagine.
Oh wow, we've got reports
Yeah.
to
And
come.
you love.
I love reports.
She is the queen of the outcomes of those at our organization. So if a referral is made, so it might be made by a supports coordinator, or it could be a self-referral from somebody,
Absolutely.
right? Because everybody who's a participant in a senior resources program got a letter, correct? And so
Correct.
by participant, we mean they could be in, please correct me, in any of our programs. My Choice Waiver,
Right.
our case coordination and support, our targeted care management, our private pay programs, our Care Connections, that's a private pay program, anything like that. They just need to get some kind of a service and have a chronic condition or something.
Correct. So if someone is not already a participant of senior resources, they just have to be willing to become a participant.
And so they can do that by calling our options department at 733-3585, Monday through Friday, roughly from 8 till 4, and talk to somebody about the needs. And although we've talked about options lots of times, but I never, it's always one of the last things I say on the show, it's really the gateway to the services here. And so then they'll get you enrolled in whatever is appropriate, and then you can mention in that call that you're interested in the enhanced care services as well. So, so after a referral is made, what happens? Does it go to you right away, or is there another process?
Yeah, it's a good thing. We have a team. It's small. We're building, but the initial step, the first step, is a referral is made. Again, that can be made from a supports coordinator, a community health worker, a self-referral. A family member could call and inquire about the program. It goes to our scheduler biller, who has a lot of experience in sort of figuring out, first of all, how will this work with your insurance? Our goal is to provide the least out-of-pocket costs for all of our participants for all the services we provide. And oftentimes, the services I offer are billable. They're physician-based, they're provider-based, and so many insurances cover 100% or a large portion of the services. So there's also some background questions as far as just demographic information. So the next step is, where do you live? Who's your emergency contact? How do you prefer to be contacted? Is there a day and a time that works best for you? Some people don't like early mornings. Some people prefer Tuesdays, whatever their preference is. After that initial intake call is done, the insurance is verified, that case, that patient, is referred over to one of our community health workers. Currently there are 2 on our team, and I think a 3rd coming soon. And then they contact the participant, anticipating there'll be a patient. And the next phone call takes quite a while, somewhere between 30 minutes to an hour. That community health worker is going to ask the participant to give us a list of all of their medications, review their medical history, review their family history, review their surgical history, all of the things that you would normally fill out as a new patient packet when you go to the doctor.
Just going to say that.
So
it's
it's
like
about
the first visit there.
It's like 6 or 8 pages typically when you go to the doctor for the first time, and they want to know, how many children do you have, and what age is your mother living, and what age did she pass if she's not, and what did she die from.
Right.
So all of those questions, plus all the surgeries you've ever had, and then also the finalizing is, do you have any current concerns? Maybe someone has a rash, or maybe they check their blood sugar regularly and it's been higher than what they felt was normal or safe. So those could be pushed forward onto the referral over to me. So finally, after those, there's a large piece of background that's happening before I ever even see the patient or the case. We do communicate as we're growing this program. So I have a little bit of information on the front side, but I might not always. After all of that data and information is built into a patient chart, into an electronic health record, it's then scheduled for me. So the first visit will be scheduled. I'll go out to the patient's home and review all of the information that has been given, look at all of the medications, talk about the current concerns, verify the information is correct, because something may have changed in a week or two, or maybe there was a misunderstanding. Someone thought they were on a medication and they're no longer taking it. And that first visit, I am scheduled about an hour, and have been finding it takes a full hour, or a little longer, depending on the situation.
Great. So, and that's not typical when you go to the doctor's office. It's rare. I mean, I guess I don't know in a geriatrics office, not being old enough to qualify for that yet. But typically, you might be in a doctor's office for an hour, but you're not in front of a physician for an hour usually. And again, that's not meant to be a slight. It's just unfortunately the way a lot of our systems have worked.
Correct.
With less people, less physicians or providers and more people. So I'm sure that when the appointment is made, that they're told to plan on an hour and to be able to go through this, and then you make up with them or with their primary care provider a plan of care for them going forward, right?
That's correct. And it may be, oftentimes one of the first questions is, how often will you come visit me? How often will I have an evaluation? And so the easiest way for me to answer that is I truly believe that for our older adults, the recommended guidelines are that our older adults should be seen at a minimum every 6 months. So it may not be exactly January and June,
Right.
but it should be about January and about June. And then in between those times, and in between that every 6 months, if we're currently working on something like a blood pressure medication change, that's something that needs to be monitored. And that can be monitored remotely, as we talked about, but it may also need to be required face-to-face. There may be times that it is appropriate for me to see a patient every few weeks or every month, depending on the complexity of their concerns or the findings that I find seeing them. Is it expected that I will go every month and see every patient? Probably not, especially many of our patients, because of the services they've received, and have so many layers of support between their supports coordinator and all of the other assistive programs that we put into place. They actually do quite well independently in their home, and so they may not require as much face-to-face evaluation from a provider.
So each case is different. It's person-centered. It says everything that we
Correct.
do.
Yep,
Wonderful.
absolutely.
So we've been in this program now for a month-ish.
This is our third week.
Third week. Well, by the time some people see it, it's a month-ish. So, and so that's exciting. So really, when we tell you this is new, this is really new, as of August 12th when we taped this. But tell us a little bit. I know you've seen patients. So all of them so far, have they been those first visits, or have you had any reoccurring ones yet?
They have all been the first visits.
Okay.
I do have some follow-up visits scheduled, but there wasn't anyone that needed a second visit as of yet. So they've all been first visits.
Okay.
They have been a mix of patients. I think all of them have had no less than 6 chronic health conditions. Okay. People may wonder what those are, because I think oftentimes we don't realize that we have a chronic health condition because it's being managed. But some of the major and common health conditions we have and that we see are diabetes, high blood pressure, anxiety, depression, chronic pain, hyperlipidemia or high cholesterol, coronary artery disease or hardening of the arteries, congestive heart failure, COPD or chronic bronchitis and chronic asthma. Oftentimes people are being treated for heartburn disease or gastrointestinal reflux disease or GERD, which we don't really realize that that's a chronic and ongoing condition,
Right.
but it really is. Chronic constipation, urinary concerns on both sides. Maybe we go too frequently or maybe we can't go as easily as we'd like. So all of those fall into some of the more common diagnoses, and then there are a lot outside of that,
Right.
like Parkinson's and Alzheimer's and dementia and some of those other ones that require a little bit more complex management.
Have you seen anything, and I know you can't get into any details, but anything surprising or just unusual, something different than you expect to see?
No, I've been very pleasantly surprised in sort of what I had expected. I will say one of the more maybe surprising in the good way is how welcoming the participants are. I think is probably the best thing to say, is that I think that because they're used to the support services that are provided, me stepping in doesn't feel foreign, and that's a nice thing.
Good.
So,
And they can, so as you said, you could work with their primary provider, or they can choose you as their primary provider if either they don't have one, because some people don't. They rely on urgent care or the emergency department, right?
Correct.
That's my understanding. Or they may have one, somebody could have retired, that happens a lot, or moved, and they have a change, or just have a really hard time getting in or something, a variety of reasons, but they can choose you. Has that happened?
It has happened.
Okay.
And I also have a supervising physician who is a board-certified internal medicine physician. Her name is Dr. Rashmi Janeja, and she's available to me 24 hours, 7 days a week, via phone and or text, to review cases with me if I have a question, if I would like a second opinion, or if I felt just like I want to run something by you. So Dr. Janeja is available for me. We have a strong relationship, and she is extremely passionate about the care of her patients. And she's also passionate about the growth of our team and to be able to be supportive as well. And so choosing me as a nurse practitioner, I think sometimes the question comes up to say, I want to see the doctor. If you chose me as your nurse practitioner, you probably would not see a physician that would come to your home. But again, she's available for me anytime that I would need her.
Wonderful. So Kim, this has been an exciting new program. What's next?
What's next?
Yeah, or you said you're maybe growing the team. What are your
Correct.
hopes? So how many people do we have enrolled in it now, and what are your hopes, or what's the capacity of it, I guess is the bigger question.
Well, capacity is pretty open right now. My hope is that no practitioner would have more than 500 patients to oversee, which is much less than a typical primary provider. Again, I feel it's very important for our practitioners to really have the opportunity to build a rapport and build a knowledge of their patient. So having that time available to be able to do that. So we have Laura right now. We're in the process of hiring a second nurse practitioner currently, so we will be able to cover our entire service area of Ottawa, Muskegon, and Oceana. I do think that we will grow, especially home-based services. As we know, people don't necessarily, with the pandemic, want to go to a doctor's office. So having a home-based program that can come out and see them, I think, is really appealing for a lot of people, especially people where transportation and other issues come into play.
And we
with
haven't even
trying to
talked
come
about it.
in.
So we've had this in the works before pre-pandemic. This wasn't, but it's just the timing of it, as you said. The fear of going in, understandable fear of going into a doctor's office, the fact that they were shut down for a while and couldn't really see unless it was an emergency. And then transportation. I mean, we could go through 10 other reasons why this is so important, but we don't have that much time to do that.
We're
But
getting close to the end.
yeah, so I just want to quickly, in the last minute or so that we have left, just remind people that if you are a participant in a senior resources program, or if you would like to be, you can call our options counselors at 733-3585. If you're already a participant and you're interested in this, they will know how to direct you that. If you are not a participant and you want to be, they'll know how to do that as well. And again, that doesn't matter your financial things, which frequently do impact what program you're in. If you have the resources, whether it's private insurance or private pay, you can still be part of this if you're interested with that kind of a condition. And so 733-3585, and if you can't remember that, I always urge you to call 211, which is available 24 hours a day, 7 days a week. They know us well. They used to be part of us, so they know how to refer you to us as well. So we will probably be revisiting this, I think, down the road in a few months and check in to see how things are going. But for now, Kim and Laura, thank you so much. This half hour flew by. Super important information, and I'm excited to learn more about it myself.
Thank you for
Thanks for
having
joining us.
us.
Thanks for joining
Lisa.
us. We hope we'll see you again soon. Have a great day.